Then TRUS, transrectal ultrasound with biopsy, will also help you to make out the definitive diagnosis. What are the three main indications of TRUS plus biopsy? A short answer question which you have to be confident to answer in the tomorrow's exam. PSA more than 10, PSA velocity greater than 0.75 per year, or any abnormal digital rectal examination becomes an indication for TRUS with biopsy. We also do bone scan, plain radiograph of the pelvis end. We combine DRE with the PSA, which can be able to find out about 60% of prostate cancers. Now let us look how the TRUS will look like. This is the normal area of the prostate, and this is the tumorous area in the prostate. So this is how, as a hypoechoic lesion in the peripheral part of the gland, you will identify the presence of prostatic cancer. This is another example. Here you can see one hypoechoic area, and there is a small hypoechoic area over here also, and when the biopsy was done, it is being found to be, from this hypoechoic area, it is found to be adenocarcinoma. Then this another patient in whom an axial T1 weighted image, when it is being done, you are able to see one typical swollen part, which is obturator lymph node, which is commonly enlarged in case of the prostatic cancer. Then you will be subjecting the patient to the bone scan, where you can identify the metastasis which has occurred into the 12th rib in this case, and also into the thoracic spine, classically on radionuclide bone scan. This is another example of an isotope being excessively picked up in multiple areas in the case of the metastatic prostate cancer. This is a plain radiograph where you are able to see a lot of sclerotic areas. Sclerosis means blastic lesions. Prostate is known to lead to metastasis, which are blastic metastasis, is what you have to fundamentally remember. And in pathology you studied, we use what is called as a Gleason scoring system histologically in order to grade the prostatic cancer, is what need to be understood. So how do you stage prostate cancer? Confined only to the prostate, non-palpably stage A. It is a nodule in the palpable nodule, but confined to prostate is B, beyond capsule is C, metastatic is D. That's how you broadly divide. How do you treat? The definitive therapy is radical prostatectomy. Remove the entire prostate. Then what will happen? See, from the bladder, what is the prostate doing? Prostate is the cave through which there is a tunnel, prostatic urethra, right? So if you remove the prostate, you are damaging prostatic urethra. Then what you need to do? The remaining penile urethra core, directly you join it with bladder. Because when you remove the prostate in radical prostatectomy, prostatic urethra is also out. So the remaining part of urethra you will join with the bladder. Radical prostatectomy ho gaya. Directly from the bladder into the penile urethra, urine will pass. So, especially the main challenge with the prostatic cancer is, what is the main challenge? Dada Jitendra Singh is your patient. He worked in 1973 ward, and 73 or 70, whatever. Then he is a top cavalryman, he is a very happy man. His wife died, first wife in 1950, second in 1960, third in 1980. Now he has got the fourth wife, and he totally had one cricket team full of grandchildren. Everyone loves Dada Jitendra Singh because he is a very jovial man, always ready. He already had one vertebral bullet, souvenir bullet in the war. He is a lovable Dadaji. he is being found to have prostate cancer. And the granddaughter of the Dadaji studies in Patiala Medical College. नए दादाजी चलो आपका prostate को निकाल के radical prostatectomy करके you have to live up to 100. Then Dadaji will say, 4 women I have disposed in my life, 4th is waiting to get disposed. At this age, why do I need surgery? Will your anesthetist will be courageous to operate on me? I already have a bullet in my spine. Elderly people, very elderly people, in the evening of their life, not even evening, midnight of their life, presents with prostate cancer. In them, do you want to operate or not is number 1 ethical, difficult to answer. Second, they will not be fit for surgery from anesthetic point of view. So there are all the challenges. If the natural life expectancy is less than 10 years, and if they are asymptomatic, then watchful waiting is all that is warranted, is what need to be remembered. Now this is the radical prostatectomy. What you do is you do an incision through the abdomen, this is the bladder, and this is the prostatic urethra, and this is the penile urethra. Okay, doc? And here you have this malignant tumor, you remove that, and what did you do? Directly the bladder is connected with the urethra and you pass the catheter. So this is what is done in the radical prostatectomy, is what need to be remembered. If it is locally invasive, then you can give radiation and androgen deprivation. Only thing is it will prevent the local spread. Why? Prostatic cancer survives on the testosterone support produced by the Leydig cells from testis. So either you do orchidectomy or you do medically, you try to give a drug which will be like aromatase inhibitor or a testosterone receptor blocker, finasteride, flutamide, all these drugs which are available, you can give and create a medical castration is the another thing that you can be able to do. If it is metastatic, then you try to do orchidectomy, anti-androgens, LHRH agonists like leuprolide. You may say, what sir? Leuprolide is LHRH agonist. Then LH should produce testosterone. No. What is the specialty of leuprolide? If you give in pulsatile manner, as what you do in the case of a infertility clinic. In infertility clinic, to induce ovulation, you need LH to jump. For that, what will you give? Lupron. You give leuprolide pulsatile way, so that LH produces ovulation occur. Whereas in prostatic malignancy, continuous LH if you give, it will suppress LH production. Leuprolide is a LH-RH agonist, doctor. So that is what need to be remembered. We will discuss all this in the pharmacology in a more detail. So that is all the story of prostate cancer. So what is the summary you will write in the exam? Adenocarcinoma is a word examiner is looking for. PSA velocity, importance of PSA. Then the combination of the three, TRUS plus PSA plus DRE. What is your protocol of evaluation? When you want to do, when you don't want to do TRUS biopsy. If you comment on that, yes, you know the topic of the prostatic cancer. Then kidney cancer, doctor. इतना किडनी के बारे में बात करने के बाद किडनी कैंसर तो बात करना ही पड़ेगा. It is twice more common in the men, just like prostate. And von Hippel-Lindau syndrome, like autosomal dominant conditions, also can have good number of cases idiopathic. It can metastasize to the lung, liver, brain, and bone. And sometimes it may be discovered incidentally if you do CT scan. This is a normal kidney. This is a kidney with the cancer. Right kidney. This is a liver, right liver. And this is the left spleen. Okay. So it may be found incidentally. What is the important risk factor for renal cell carcinoma? Don't forget, smoking is the most important risk factor. those who take phenacetin, ADPKD like conditions, those who are on chronic dialysis, they will develop dialysis associated cystic disease and they can develop. And mercury cadmium like heavy metal exposure can also lead to development of renal cell carcinoma. What is the most common symptom, doctor? Hematuria. Hence, what is the rule? Any person above the age of 50 without UTI, without stones, presents with hematuria, think of the possibility of renal cell carcinoma is a very important role. Abdominal or flank pain, 50% of cases, and as a ballotable abdominal or a flank mass in about 40%. Weight loss and fever like constitutional symptoms can be the presenting feature. This is a very disgusting thing about the renal cell carcinoma. Why? Somebody with weight loss, with fever, with hematuria, we think of renal TB, which also can present with fever, weight loss and hematuria. But when you have done ultrasound, when you evaluated, then you discovered renal cell carcinoma is what need to be remembered. Renal cell carcinoma, just like lung cancer, is a bundle of paraneoplastic syndrome. What is paraneoplastic? Non-metastatic manifestations of the cancer is paraneoplastic. It can produce a lot of erythropoietin. Polycythemia can be there. It can produce parathormone leading to hypercalcemia. It can produce renin leading to hypertension. It can produce cortisol leading to Cushing's, just like the small cell cancer, oat cell cancer, which we have studied in bronchogenic carcinoma. And it can produce gonadotropins leading to men becoming women, women becoming men. Anything can happen with the renal cell carcinoma. But what is called classic triad of clinical features of renal cell carcinoma, doctor? Hematuria, flank pain with an abdominal mass is classic. Classic means what? It is never found. It is rarely found. Shakespeare's novel is a classic because we don't read that. What is more, Grey's Anatomy is classic. If you read Grey's Anatomy, you are very close to a mental asylum. So we don't read it, but it's a classical treatise in anatomy, right, doc? Now, what's the diagnosis? Ultrasound can help you. You can see this, the tumor mass. Any tumor is what, doctor? Hypervascular. Increased vascularity of the tumor can also be demonstrated by the renal ultrasound is what need to be remembered. Abdominal CT is a very optimal test. Why? With the CT you can show whether the renal vein is invaded by the renal cell carcinoma, whether it is not invaded by it, whether there are any metastases to the surrounding tissues. So for the staging, CT is wonderful. Then how do you treat? Radical nephrectomy. In this, what is radical about it? Remove the kidney, remove the adrenal, remove the gyrotas fascio, and excise the all nodal tissue which is surrounding the hilum. That is what it is called as radical nephrectomy. So that is the story of renal cell carcinoma. What are the 5 lines you will write? Paraneoplastic symptoms, classic triad of features which is only classical, and that word above 50, without stones, without UTI. I like to evaluate every men and women for renal cell carcinoma is very well appreciated, is what need to be remembered.